is Roger Green, host of the Surfing the MASH Tsunami podcast. This week, we're offering 5 conversations from episode 21, our review of the updated clinical practice guidelines from EASL, EASD, and EASO, with Louise Campbell and co-authors Elisabetta, Bugianesi, and Frank Tacke. Plus, from the vault, a discussion from 2023 about clinical care pathways. This conversation focuses mostly on screening, diagnosis, and case management recommendations in the guidelines, although it starts with me saying that, like Louise, I was impressed by resmetirom and doubly impressed that all these adjustments were made within a month at the end of the process. Frank praises the, as he puts it, very engaged Delphi panel that reacted and voted quickly and fairly consistently. He proceeds to discuss how the Delphi panel was formed. From there, I asked the co-authors to discuss high points in the discussion of screening, diagnosing, and managing patients. Elisabetta starts by stating that the resmetirom approval is creating a great push for screening because physicians now feel there's something they can begin to do to help their patients. She describes an approach that begins with FIB4, proceeds to VCTE, and offers 2 paths for patient management. This should help the system identify patients before they become cirrhotic or before HCC occurs in pre-cirrhotic patients. Frank points out that this set of guidelines does not rely on biopsy for risk assessment, which he terms a major breakthrough. Louise lauds the document's approach to diet advice, specifically the broad range of diets that will make the document valuable across the world and for primary care physicians who work with patients from different ethnic groups. Frank adds that the guidelines have adjusted thresholds and other, as he puts it, adaptations to the ethnic background of the individual. This includes taking socioeconomic factors of a target country or a target community within a country into account. As Louise and I each comment at least twice during this episode, these guidelines are exceptionally impressive in terms of their scope and forward-thinking recommendations. Hopefully, this will energize you to review the actual guidelines, for which there's a link in the article write-up on the Surfing the MASH Tsunami website. Each conversation is uplifting in its own way, so just sit back, listen, learn, absorb, enjoy. And when you're done, join the conversation in our LinkedIn discussion group.
Frank Tacke.
We had a very engaged Delphi panel that every recommendation you find in there, even like some of the figures were voted on, and you find in an appendix also the number of how many people consented. So consensus of at least 75% were needed for each recommendation. And if there were good criticism, good comments, we changed it, and then it underwent again the Delphi voting until we really shaped using the swarm intelligence of our panel to get the essence and the most practical recommendations.
Roger Green.
As Louise says, and I'm sure we're not the only ones, it's a fantastic document and we congratulate you for it. But I'm even more impressed when I understand how quickly you put it together. I know Delphi panels take time. They're not the fastest thing in the world, although they're remarkably valuable. But to move that quickly, so how did you folks decide who would be on the Delphi panel?
That was not on us to decide. So we were able to make recommendations to the governing boards of ERSL, ESD, and ESO. But in the end, the Delphi panel was appointed by the respective societies. And for instance, there were some pathologists on the Delphi panel. There were patient representatives on the Delphi panel. It was people from South America were on the Delphi panel. So of course, we were allowed to recommend some of our colleagues, which we would have loved to have on the core panel, but it was not possible due to like limited numbers of people by society. But in the end, they were all appointed officially, like with a letter from the different societies to be part of the Delphi panel.
So, for example, how many patient representatives were there? I think that's one of the things we talk about again on this podcast is that patients and allied providers don't really have a voice at the moments that matter most. How many patient representatives were on the panel? Just curious.
It's definitely Achim Kaus, Marco Korenjak, and another, I think it's 3 or 4 patient representatives.
That's 10%. That's
that were there.
Pretty good.
I think the problem with patient representatives in the field of MASLD is that we do not have like a single MASLD patient representation organization. So you have really very strong voices in the field of liver disease who have oftentimes a background in viral hepatitis or oncology. Then we have strong voices in the field of metabolic diseases like type 2 diabetes, obesity. But bringing those people together is actually something I think we will see in the coming years much more than we see it at the moment.
Speaking of that, I had a comment from Mike Patel from the Fatty Liver Alliance, who you all know, which is that he's been telling people that he cured his MAS score and it healed his liver. And then you set the level at 248 and his is 256. So he says now he's not healed anymore. You can't use that story, at least until he gets his level down further. So I was talking with him this morning. I said, So what you feel about the guidelines, and that was one of his comments as a patient advocate with fatty liver disease. Okay, so Louise, if you don't have any more questions about that, or Elisabetta or Frank, anything you want to say, I'd love to know what you consider the high points. I'm going to go one issue at a time through some of the major topics. What you consider some of the high points on the element about screening, case finding, diagnosis, monitoring. What are some things that people should be paying attention to as they read?
Elisabetta Bugianesi.
Well, first of all, we have now the first drug approved, so this is a great push to make screening, because one of the objections that has been done before is, yes, we do screening, but then what we are going to do? Now we have the first drug approved, and probably we'll have many more in the next month and year. The second thing is that our pathway for screening the risk of advanced fibrosis is exactly the same of all other societies. So it is very simple, very affordable, and can be done in any kind of health environment. So FIB4 is the first approach that should be assessed in at-risk people, that is, those with type 2 diabetes, those with obesity, and at least one more cardiometabolic risk factor, or those with elevated liver enzyme, which is the usual reason why patients come to a pathologist. FIB4 is easy to be calculated, and it's cheap, so it can be done in every country. And we have the same algorithm of the other American Society, Asian Society, and so on. So a two-step approach. If FIB4 is lower than 1.3, this is a low risk. If FIB4 is higher than 2.67, this is a high risk and should be referred to a pathologist right away. If we have an intermediate risk, 1.3 to 2.67, then you need a second line assessment that should be done by VCTE, FibroScan. Here we gave two options because of the discussion we had with the hepatologist. So one option, particularly if you have a number, a value to the lower end, so toward the low risk, you can start to manage intensively for at least 1 year and reassess. But if the value of FIB4 is closer to 2.67, then it is much better to refer this patient to a second line assessment, VCTE, FibroScan, that can be done by a pathologist, but can also be done by the radiologist or whoever has the opportunity to have a FibroScan. And here is the value is equal or higher than 8, then the patient definitely is at risk of developing progressive liver disease and should be referred to a pathologist. This is more or less the same approach that has been also indicated by the EASL-Lancet Commission for Liver Disease in Europe. The aim is to find out liver disease before it is too late, so to prevent the occurrence of cirrhosis and the onset of hepatocellular carcinoma. And if we can in some way catch these people who are completely asymptomatic at an earlier stage of the disease, we can do much more compared to what we can do when they are already cirrhotics.
Compared to prior versions of guideline recommendations, at least from EASL, is that liver biopsy is very rarely needed. Of course, it's needed in the clinical trial setting if you really want an accurate staging and grading. Grading means inflammatory activity, or you want to diagnose the steatohepatitis, or if you have differential diagnosis. But we do not need the liver biopsy anymore for this risk assessment. I think that is a major breakthrough also for the individuals affected by MASLD. And as Elisabetta has pointed out, we have so much more evidence now for interventions that work and that can be applied. That refers to lifestyle. It's also bariatric procedures where we have a lot of evidence now that the weight reduction that you achieve actually results in a benefit that is meaningful for the patient outcomes or for liver-related outcomes.
Excellent point. And another thing to commend you folks for is exactly the role that you did not give to biopsy in the process, or things that could be done without biopsy, because even in the States, shortly after the approval of resmetirom, a investor client had me go out and talk to just basic garden variety lay hepatologists, half of whom were concerned they'd still have to do biopsies. The better job of getting that story out, I think it will make this easier for everybody.
Louise Campbell.
No, I think the other strengths of the document were the dietetics advice, the broad-ranging amount of diets, but just looking at the key points of each area actually were very clear. And for me, they're applicable to any of my clients, irrespective of race or ethnic background or their diet. A lot of my clients don't necessarily have a Mediterranean-style diet. It's more Asian or Indian, and that therefore it can be adapted. And I think that ability within the guidelines to be applicable to lots of other areas, again, is a great win from that document. And the definitions of different causes of steatotic liver disease, so it's not just obesity, it's not just weight, it's not just diet. It's very, very clear, and I think it's very helpful for primary care physicians coming into the field, looking at their early diagnosis, particularly obesity and endocrine, again, looking for those. So I think I can see lots of positives for screening and agree that we now have a treatment and we need to be starting to screen.
Yeah, maybe, Louise, if I can just re-emphasize what you said. I mean, in the guideline, you find tables with adjusted thresholds, for instance, for the BMI or for waist circumference, which of course has or requires some adaptations to the ethnic background of the individuals. But also in the lifestyle recommendations, there are economic constraints. There are different, let's say, preferences and abilities, for instance, to implement a physical activity or certain dietary changes. So an important aspect is to set realistic goals for adjusting the lifestyle, minimizing ultra-processed food or highly processed industrialized food, kind of enrich the diet for vegetables, for proteins, for more healthy diet, but also take into account what is realistic. So set realistic goals also for the weight reduction. I think that's very important, and we try to be as open as possible to the way leading to the success. So like if you compare the different trials on dietary interventions, in the end, the diet quality is important. And in the end, also the weight reduction we know is very important in implementing the lifestyle changes. And this probably needs to be adapted to the individual's preferences and abilities.
And if I may add, although these are guidelines for adult patients, this may also have an impact on children, because if family learn how to eat, how to avoid ultra-processed food or sugar-sweetened beverage, they know that they are detrimental to their children, then it becomes prevention also for the youngest.
Yeah, which is, I think, an excellent point, because the reason the disease grows is because people's diets get worse over time. So if this could become part of the process to reverse that trend, then I think you actually start to find one more way to have the ability to slow the rate at which people come into the disease.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingmash.com. Next week, Jeff Lazarus will join us to discuss the Healthy Liver, Healthy Lives initiative. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.